Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to the American Academy of Orthopedic Manual Physical Therapists podcast. Today we have Dr. Leah Ruggirello with us to discuss her case study, which was featured in the AAOMPT publication of Hands On. But before we introduce Leah in person, let me give you a little bit about her background. Dr. Leah graduated with degrees in exercise science and psychology from North Central College in Naperville, Illinois. Then she went on to receive her doctorate of physical therapy from the University of Illinois in Chicago in 2010. She's also achieved her orthopedic clinical specialist certification through the American Physical Therapy Association and pursued her fellowship in orthopedic manual physical therapy at the University of Illinois at Chicago. Since that time, she's been involved in mentoring of manual orthopedic fellows in training. She has also taken an interest in vestibular and orthopedic rehabilitation. Dr. Ruggirello is recently relocated to Alaska and works for United Physical Therapy in Anchorage. Leah, welcome to our show.
Hi, thanks for having me.
My pleasure. Thanks for taking time out of your busy summer. For those of you that know Leah is Leah Ruggirello, she's also added Einhorn to her name as of last Saturday. So congratulations on your wedding.
Thank you very much.
All right, so we'll get right into it. Leah, can you tell us about your case study? Give us the basic background and purpose.
Absolutely. So I had a patient who was a 23-year-old pharmacy student who was post-op ACL reconstruction. After about 6 weeks of therapy, which was actually 8 weeks post-op, he had a little problem getting started because of his insurance. He was still having a really difficult time recruiting his quad. And at this point, I thought he was experiencing arthrogenic muscle inhibition, which, for those who aren't familiar with it, AMI, as we often call it, is marked quad atrophy, or weakness, I should say. And it's partially due to muscle atrophy, and then it's partially due to ongoing neural inhibition that prevents the muscle from being fully activated. So it's present in up to 70% of cases after ACL reconstruction, and it can be a really big barrier to rehab. It can persist for months, or in some cases years after injury or repair. It can impair physical function, increase risk of re-injury, contribute to the development of knee OA. So in our first 6 weeks of therapy, it was kind of business as usual. We did strengthening, treated all of his joint and muscle impairments, but he just wasn't progressing as he should, or as I'd expect. So at this point, we decided we should take a closer look at things or just try some different things out.
Tell us, what was the reason that you chose each of the 4 interventions you pursued?
We decided to look at a couple different interventions and look at what happened to the strength of his quads before and after each intervention. So the first we did was just kind of look to see what exercise did. And our little control, so to speak, of exercise was 3 sets of 10 straight leg raises and quad sets, so nothing fancy. We did that one session and we just measured his strength with a dynamometer before and afterwards. A week later, at his next session, we looked at the effect on strength of a lumbar manipulation. So we did the L3, L4 segment. We measured his strength before and after the manipulation. And then we did the same exercises, the quad sets and straight leg raises, and then tested strength again. Then the next session, we did the same, except used tibiofemoral non-thrust manipulation or joint mobilization. And we did an anterior to posterior mobilization for about 5 minutes. We measured strength before and after the mobilization, and then we also did the strengthening and then measured the recruitment of the quads afterwards. And then our final intervention was the use of NMES, set to, kind of standard Russian parameters to try to elicit a deep muscle contraction. Again, we measured the recruitment before and after each that intervention, and then did the same exercises again, and then measured strength after that also. So the various different reasons for choosing these interventions. There are lots of different things that we probably could have included. There is research to support using lumbar manipulation for quad recruitment. Grindstaff several years ago did a study on healthy controls and found that there was improved quad strength after doing lumbar manipulation. There is one case report by Dr. Jayla Seeland from a few years ago in a patient who was post-op ACL reconstruction that he did lumbar manipulations on and found that he had an improved quad recruitment afterwards. But we felt like the lumbar manipulation part has kind of been shown already. There is not as much evidence showing any change in strength after tibiofemoral mobilization. There is some research that exists in the knee OA population that Dr. Carol Courtney has done. And after several minutes of mobilization, they found improved function, pain, flexor withdrawal, reflex, and several other factors after doing joint mobilization. So we kind of thought, either one of these would be good options to try in this particular patient. And then, of course, there's NMES as an intervention that's been around for a while, and it has older research to kind of support its use. So we thought we would try including that and just see if one gave us better improvements than the other.
You started your interventions when the patient was 8 weeks post-op and still not really showing great signs of quad activation. And then each intervention was recorded at 1 week intervals. Can you tell us anything else about how the interventions were done that's important for understanding the results?
Let's see. So each intervention was done 1 week apart so that we weren't doing too many things all at once to try to keep things a little bit more clear. And again, we measured the strength before each intervention, after the intervention, and then after those 2 exercises. It's important to know, too, though, that those were not the only exercises that he did in the session. After this quote-unquote experimental portion was done, we had him go through his normal post-op protocol because we by no means wanted to limit his progress any more than it kind of already was by meddling with some of these things. So each session, his exercises weren't exactly the same, but what we measured was as consistent as we could be. So that's just something to be aware of, that he was still doing his other functional exercise and other strengthening exercise after we tested the strength.
Okay, great. Tell us about the results. What were the outcomes of your 4 different interventions?
It was kind of interesting. We found that after each intervention, he had improved quad recruitment, which was really nice to see actually. He had the most change within session after doing the tibiofemoral joint mobilizations than he did with NMES or with a lumbar manipulation. So we thought that was pretty interesting. And with each intervention, NMES, the lumbar manipulation, and tibiofemoral mobilization, he had more improvement once exercise was added. There was a few interesting points to take home from that within session he found he had the most improvement after the local joint mobilizations, but that with all of them, once we added exercise, that made our results even better. So obviously showing how important exercise is in this population. There was one other interesting thing too. We actually found that immediately after doing NMES, he actually had a decrease in his quad recruitment. This is a case report. We can't make a lot of causation statements, but just something interesting that we found in this particular case, that right afterwards, it was very likely that his muscles were pretty fatigued.
After gathering all the data, what was your conclusion that you were proposing was the mechanism of why the local joint mobilizations may have affected his recruitment? And then tell us a little bit about, if you can, neuroscience behind how local joint mobilizations might affect recruitment.
Great question. I will do my best. Essentially, we're looking at a reflex loop. So manipulation, to start off, has been proposed to impact a number of mechanisms, including reduced nerve impingement, altered discharge from muscle spindles, Golgi tendon organs, mechanoreceptors, nociceptors, altered sensor processing in the spinal cord, and then altered skeletal muscle reflex. These changes may alter 1A afferent feedback to the spinal cord to cause an increase in motor neuron excitability via this Hoffman reflex, otherwise known as an H reflex. So spinal manipulation may therefore help to reduce ipsilateral quad inhibition. And we're suggesting in this study that joint mobilization locally works in a similar pathway by increasing the motor neuron excitability and the motor output. And based on the tissues that the techniques were applied to, we hypothesize that this non-thrust manipulation of the tibiofemoral joint altered the afferent input, potentially resulting in a more efficient central feedback loop. This has been actually shown to occur in those with chronic knee pain following tibiofemoral mobilization, but has not been documented in any acute knee population. Dr. Emerson Kavchak was the one who had shown that in the chronic knee pain population. We think that it's possible that the excitability of the alpha motor neuron pool and the reflex pathway or the efferent output is essentially more effective or more efficient when its corresponding afferents are activated rather than the corresponding spinal level, specifically the L2 through 4 segments in this particular case. It's also possible that the stimulation of the reflex pathway is actually velocity dependent, but not in the sense that we typically think of, as there was a greater improvement of strength with a low velocity oscillatory movement as compared to a high velocity thrust. So this, we think, just lends itself to suggest the importance of specificity when choosing clinical interventions, as being as specific as possible to the site of injury may result in improved efficiency of our treatments and quicker return of patients to their prior level of function. So that's some of the nitty-gritty of the neuroscience. I think the main point, just to make it a little bit more clinically relevant, is that when you have a patient with AMI, whether or not they've had an ACL reconstruction, try mobilizing the tibiofemoral joint to augment your strengthening exercises.
Absolutely. I really enjoy seeing the documentation of how manual therapy is not just biomechanics, where if it's tight, you mobilize it, and if it's unstable or poor motor control, you just exercise it, but the layers of effects that manual therapy can have in augmenting treatment. After having done the study or even before, does this affect your order of treatment?
Do you mean like within a session or throughout their whole plan of care?
Well, I was thinking within a session. I think a lot of people end with manual therapy, and this might be suggesting a different order of treatment.
Yeah, I think that's a great point that I actually hadn't really thought of. I think this would lend itself to suggest that you might want to start with some manual therapy to kind of almost warm the system up a little bit so that you can get a little bit more bang for your buck out of your exercises if you did them afterwards. Yeah, I think that's a great idea.
Yeah, as you're saying, kind of priming the pump to get the neurology on your side when you go out into the gym to exercise them. What was the follow-up with the patient? How did he end up doing?
Good question. The patient ended up doing really well. I think this, couple weeks really helped get him back on track. He was able to continue his plan of care per the post-op protocol, progressing his strength. He did eventually get back to playing recreational basketball. That's how he originally tore his ACL. He was a grad student, so not a competitive player. He got back to where he wanted to be. We followed up with him about 6 months after discharge, I believe is when we called him and asked over the phone how things were going. And he said he was playing basketball. He wasn't having any really residual problems that he was aware of or that he noticed, no instabilities or anything like that. He ended up doing actually very well once he was able to get some of that strength back.
So, Leah, I really enjoyed reading your case study, and that will be in the show notes for those of you who want to read the entire case report and take a look at her references. What I appreciate about the case study, Leah, is your clinical problem solving and finding a problem and then not having a specific article to draw from. You synthesized the literature and came up with some good hypotheses and then carried them out. You've worked hard ever since you graduated with pursuing your career, getting your OCS as well as your fellowship training, so your efforts and work to be a better clinician are certainly evident in your thought process and your level of clinical reasoning. Given that you have some experience under your belt, what advice would you give newer PTs who are just starting out their careers in terms of how they can develop their clinical reasoning and or their career path?
Great question. I would say try to find, if you can, more experienced PTs who you trust and you can use as your mentors. A good mentor is one of the most valuable things that you can find as a new PT and really throughout your whole career. In any class you take or new concept you learn, ask a lot of questions. Don't be afraid to ask questions. Make sure what you're learning is first legit, it's some, evidence-based, and then make sure you really understand it before implementing it with your patients. And then I would say also, act confidently with your patients, even if you don't always feel that way. Because patient buy-in is really one of the most important things that we can do for ourselves to be successful with our patients.
What are you excited about or looking forward to as it relates to physical therapy as our profession or in your career specifically? Do you have anything that's really igniting you at this point and keeping you excited?
Yeah, I think it's actually really exciting to see us as a profession forge ahead as the experts in the musculoskeletal system. As more states are getting direct access, I think education is progressing and standards are becoming higher. So, this is naturally becoming the case that we are looked at as the experts. I've recently moved to a state where we have direct access, which I haven't worked in before. And it's kind of fun. I would say it's a lot of fun actually, but with that also comes more responsibility and accountability. The expectation here that our profession, that we are the experts.
I work in Seattle, Washington, and Washington has direct access, full direct access. And I would say about as much as 30% of my caseload just comes into PT directly without having gone through the physician loop. With that does come a lot more responsibility.
Yep, absolutely. I think we have a good future ahead of us in terms of where we're going as a profession, and I think that that's really exciting.
I really appreciate you taking the time on a Sunday afternoon to speak with us.
Oh, absolutely. I thank you for having me.
I wish you the best in the future and in your career. And on that note, we will sign off. This is Rebecca Catlin from Seattle, Washington, and Leah Ruggirello Einhorn from Anchorage, Alaska. Thanks for joining us.
Thank you, Becca.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.